Sonia Labo is from Belgium and is a nursing lecturer and researcher at Hoogland University of Applied Sciences and Arts in Ghent in Belgium. Sonia in 2013 obtained a PhD in medical sciences which focused on the prevention of healthcare-associated infections in the intensive care unit. She is also a master in Arabic languages and culture. Sonia, please present your preventing infections in the intensive care unit.
Thank you very much, Nikos, for the introduction. And hi there, colleagues from all over Europe. So I'm Sonia Labo. I am a nurse from the beautiful city of Ghent, which is in Belgium. And I am happy to welcome you to this webinar dedicated to the prevention of infections in the intensive care unit. So these are the learning objectives, which I have listed for you here too. And let's start with reviewing some definitions that are important in the context of this webinar. So healthcare-associated infection is quite a broad term. It's an umbrella term, it's an overarching term, and it indicates each infection in every patient that develops due to the fact that the patient has been receiving healthcare in any setting. So a very broad definition indeed. And a subset of these healthcare-associated infections are the nosocomial infections or hospital-acquired infections, which are defined as infections that develop after the patient has been admitted to the hospital, 48 to 72 hours after hospital admission, and that were not present nor incubating at the time the patient was admitted to the hospital. Then again, a subset of these nosocomial infections are the ICU-acquired infections, infections acquired in the ICU, the intensive care unit, and they are defined as infections that were not present nor incubating at the time that the patient was admitted to the ICU and that developed 48 to 72 hours after ICU admission. Now, in this day and age where we have very sophisticated technologies that allow us to explore distant planets such as Mars, and that allow us to launch cars into the space, then we still cannot control the problem of healthcare-associated infection here on Earth. Now, healthcare-associated infection today still remains a very serious problem, and you can see this from these figures here from the World Health Organization. They state that at any one time, up to 7% of patients in developed countries, 10% of patients in developing countries will acquire at least one healthcare-associated infection. So this means that healthcare-associated infections are still a major problem, a common problem in all healthcare settings today. Now, of all these healthcare settings, the intensive care unit, moreover, is really the hot zone for healthcare-associated infection. And you can see this from these figures. Here in Europe, we have merged data from 2016 and 2017 that show us that in the ICU, 19% of patients develop at least one healthcare-associated infection, compared to 5% of patients in wards of all other specialties combined. So this is almost the fourfold, indicating that the problem is really huge in the ICU. Now here again, data from the World Health Organization, and they say like if we should take all high income countries together, then we would see that approximately 30% of ICU patients has at least one healthcare associated infection. So this is really substantial. And in developing countries, the problem is even much, much worse. So what are the reasons for the ICU being this hot zone of healthcare associated infection? Well, there are a couple of reasons. And the first important reason is that ICU patients are particularly vulnerable to developing infection. And that is because their immunity is impaired. And their immunity is impaired because of one, but mostly because of a combination of various of these risk factors. Now, the fact that they are critically ill, their critical condition, critical illness as such, already causes major derangements of all components of the immune response system. And so does psychological stress, which is, of course, common in patients who are admitted and staying in the ICU. Also, the primary diagnosis of the patient, the disease for which the patient was admitted to the intensive care unit, may be a disease that is associated with impaired immunity. For example, the acquired immune deficiency syndrome, leukemia, and there are quite another lot of diseases that have these characteristics, as well as a lot of underlying conditions that the patient may have, a number of comorbidities that may be present in the patient. Also, medications that the patient receives, that the patient is treated with in the ICU, can cause immunosuppression. Let's think about chemotherapy. Let's think about medications that are administered to transplant patients, steroids, etc. Older age, as we know, the immune system becomes less effective with older age. And so it does with certain lifestyle components, that certain lifestyle factors that the patient may have, such as smoking and such, for example, excessive alcohol use. So most of the patients have various risk factors in the ICU for impaired immunity, which makes them particularly susceptible for developing infection. But that is not all. There is more. Because as you know, in the ICU, most patients need and does have multiple invasive medical devices. And we know that these devices are really indispensable for treating these patients or also for diagnosis. But at the same time, they are very dangerous contributors to the development of infection. And first of all, that is because these invasive devices, they bypass the natural protective barriers of the patient against infection. They are direct highways from the outside world into the patient's body. For example, intravenous catheters, right? They are super highways from the outside world into the patient's bloodstream. Endotracheal tubes that are used to intubate the patient in order to be able to mechanically ventilate the patient. These are superhighways from the outside world directly into the patient's lungs. So these are also very dangerous devices for causing infection. And that's not all, because some may also have been inserted in emergency situations. For example, in a patient whose condition was suddenly getting worse, deteriorating, and the patient needed to be intubated immediately. Well, in those emergency situations, it is possible that not all aseptic conditions can have been guaranteed, right? And so that this device may not have been placed in ideal circumstances. Then another very important characteristic of any invasive device is that any invasive device is prone to biofilm formation. And a biofilm, well, you might already have seen biofilms without actually knowing perhaps that you saw a biofilm. And I think that you had the biggest chance of seeing a biofilm when removing an intravenous or a urinary tract catheter that had been in place for quite a long time. So what you see when removing these catheters, that is a kind of slimy substance at the surface and the tip of these catheters. Well, this is biofilm. And now, how is it biofilm produced? Well, it is produced by microorganisms, free-floating microorganisms. They may be commensal microorganisms or pathogenic microorganisms. And when they encounter an invasive device, well, that is a foreign body, isn't it, in the patient's body? And they like it very much to adhere to those foreign bodies, to these devices. So they start adhering to the device's surface, and they start to grow there and to reproduce, and they start to form colonies. And these colonies, they are happy there. They start to reproduce again, and they start also to produce that slimy layer, which is the biofilm that consists of sugars, of proteins, of nucleic acids, such as DNA. And they are happy, and they build layer up on layer until this biofilm becomes a quite complex three-dimensional structure. Now, in that biofilm, those microorganisms are very happy because they have nutrients. They have nutrients, and they grow and they grow. And at a certain moment of time, that complex structure becomes really big. And at that moment, clumps of microorganisms or individual microorganisms start to leave the fold, and they start to seed in the they start to move to other locations in the patient's body. So as such, you have seeding from infection from this clump to other places in the patient's body, which is, of course, very important to have distant locuses of infection that are produced by that biofilm. Also very important with biofilms is, as you see here, that these microorganisms are very well sheltered by this biofilm, by this substance. And when a patient then is treated with antibiotics, those antibiotics cannot fully reach these microorganisms because they are so well protected. So the antibiotics that are administered to the patient become less effective, and this may also lead, very important, to antibiotic resistance. And it is not all. There is another reason why the ICU is the hot zone for infections. And that is the fact that, well, ICU patients, they are often treated with antibiotics. And today, even today, unfortunately, the incorrect and the inappropriate use of broad-spectrum antibiotics, which, as you know, is associated with the development of drug and multi-drug resistance against antibiotics, well, it is still widely spread in some parts, some regions in the world, with studies reporting up to a 60% prevalence of incorrect and inappropriate use of broad-spectrum antibiotics. Now, this, of course, also makes the ICUs the epicenter of the development, the amplification, and the dissemination of drug and multi-drug resistant microorganisms, with an incidence up to even 40% in many world regions. Okay, so these are the main reasons why the ICU is a hot zone for infection. But importantly, if there is infection, there is absolutely also a risk of sepsis. Indeed. So if the ICU is the hot zone for infection, it is also the hot zone for sepsis. And I will not go into the topic of sepsis quite extensively because it is treated in other sessions within this course. But we all know that if we have no infection, we can have no sepsis. And you see here from the slides that the problem of sepsis is very considerable in the ICU. It is the most common cause of death in the ICU. There is already a very large mortality rate up to exceeding 40%. And if it progresses to septic shock, then the mortality rate can even go up to 61%. Yes, indeed, 61%. So I hope that with this introduction, I managed to make it clear that the prevention of infections in the ICU and thereby sepsis is really of utmost importance for all clinicians working in the ICU. And what we see is that of all these infections, there are 4 types that are accountable for 80% of all healthcare infections that develop in the ICU. And therefore, they are often referred to in the literature as the Big Four. I'm sorry for the noise. And these are ventilator-associated pneumonia, central line-associated bloodstream infection, catheter-associated urinary tract infection, and surgical site infection. So let us have a look at these four main culprits, and let us start by ventilator-associated pneumonia. So ventilator-associated pneumonia is pneumonia that develops in a patient 48 to 72 hours after this patient has been intubated to be mechanically ventilated. It is especially caused by gram-negative aerobes, and it is the most frequent infection in intubated patients. And as you can read from the slide, there is a very large associated and even attributable mortality. There is an associated morbidity, and the development of ventilator-associated pneumonia is a significant economic burden for the patient, for the healthcare system, but also for the society as a whole. Now, the name ventilator-associated pneumonia, well, I think it's a bit misleading, because it is not the ventilator as such that creates or that is responsible for the development of the infection, but it is the device, it is the endotracheal tube, of course, that device that is, as we have mentioned earlier on, a direct highway from the outside world to the patient's lungs, that bypasses the patient's natural protection systems and clearance systems, and that is very prone to biofilm formation. And as such, we see that patients who have an endotracheal tube are at a 21-fold increased risk of pneumonia compared to patients that are not intubated. So the risk is really substantial. And the primary mechanism for microorganisms to translocate to the lungs of the patients is through microaspiration. Now, it is well known that within a couple of hours after a patient is intubated, then a colonization process starts. On one hand, in the oropharynx, and what we see there, that is colonization and then contamination from the mucosal surfaces in the oropharynx, the dental plaque, the sinuses, etc. And on the other hand, in the stomach, we see that there is colonization of gastric secretions. The primary source is there, the small bowel. Now, these secretions from the oropharynx that are contaminated, they can descend down alongside here the endotracheal tube towards the lower respiratory tract, and the secretions that are contaminated and that are in the stomach, they can reach the respiratory tract by a mechanism of reflux. And then they will accumulate above the cuff here of the endotracheal tube. But if there are faults in that endotracheal tube cuff, or if the cuff is insufficiently inflated, what you see here, then this will cause the bacteria, most of the time these are bacteria, to go directly into the lungs of the patient and as such cause pneumonia. So this is ventilator-associated pneumonia. And let's move on to the second culprit, and that is central line-associated bloodstream infection, which is the main complication of the use of intravenous catheters, especially non-tunneled central venous catheters. They are associated with the largest amount of central line-associated bloodstream infections. As you can read from the slide, also here, there is a high associated morbidity, mortality, and high associated excess costs. And there are four main mechanisms by which the central line-associated bloodstream infection can develop. And this one here is the most frequent mechanism. What we see here, this is the catheter, this is the patient's skin. We see that the most frequent cause is that microorganisms that are here at the insertion site, at the skin of the patient, are introduced into the bloodstream together with the catheter at the time of catheter placement. The second most frequent cause are contaminated catheter hubs or junction ports, right? And the microorganisms here that are responsible for these two processes are either, well, commensal pathogens here, mostly from the skin of the patient, but they can also originate from hands of clinicians or from contaminated materials or disinfectants. The other two mechanisms, that is that there is contaminated infusate or that there is seeding from a distant locus of infection, are far less common than the other two. Here again, as we said, the catheter is a device that is a direct highway, easily transversible for microorganisms straight into the patient's bloodstream, and is also very prone to biofilm formation. Third in the row is the catheter-associated urinary tract infection. And this is, as the name it says, of course, urinary tract infection in patients with indwelling catheters, urinary tract catheters. The daily risk of developing an infection is up to 7%. So each day a catheter remains in place, the patient has an additional risk of 7% of developing infection. And if we know that in the intensive care unit, a lot of patients really require such indwelling catheters to closely monitor their urine output, we know that this is a very important infection, very common in the ICU. Most of the time there are no signs, no local signs of infection. The patient may have fever, then maybe there are positive urine cultures. And again, here there is a considerable associated morbidity and mortality, and of course the costs associated are also substantial. Now here again, the device, the urinary tract catheter, it bypasses the natural defense mechanisms of the patients, which normally prevent interactions between the bacteria at the epithelial cells of the urinary tract, right? And it also inhibits the natural, the mechanical wash-out effect of the urinary stream. Also, again, biofilm formation. Also, urinary catheters are very prone to biofilm formation. And the pathogens can invade the bladder, both at the time of catheter placement and also when the catheter is already in place. At the time the catheter is being placed, then we see that microorganisms inhabiting the meatus or the distal urethra can be introduced together with the catheter into the bladder of the patient directly, but there can also be breaches in the placement procedure which may then be responsible for the development of infection. Most of the time, however, the infection is developing when the catheter is already indwelling, when the catheter is already in place. And then there are two ways. First of all, there can be extraluminal contamination, so outside the lumen, alongside the catheter, and that is then due to microorganisms that are at the perineum or at the meatus and that ascend into the urinary tract. It can also be a matter of inside the lumen, intraluminal catheter, and then the contamination here is due to a contaminated drainage urine bag or catheter drainage tube junction. Last but not least, we have the surgical site infections. Surgical site infections that are, well, any surgical site infection prevents, of course, from a operative procedure that the patient has. And the CDC, the Centers for Disease Control and Prevention, classify these surgical site infections according to their depth and according to their locations into either superficial incisional, deep incisional, or organ space surgical site infections. they are, as you can see here, very prevalent. And as you can see here on the slide, also these infections are associated with quite some extra cost, extra length hospital stay, and a considerable additional mortality rate. The causative pathogens here, they usually originate from the patient's flora, and so they are endogenous. They can be from the patient's skin, the mucous membranes, the hollow viscera from the patients, and they can contaminate the surgical site locally during the surgical procedure. Then we can also have seeding from a distant focus of infection, and that typically occurs in patients with prosthesis surgery or other types of implant surgery. And here again, this is comparable to what we have seen for these medical devices. In fact, these implants are also devices, foreign bodies, so they provide an excellent nidus for attachment for microorganisms. Causative pathogens may also have an external source. They may also be exogenous, and then we see that they mostly come from the members of the surgical team that did the procedure. They can also be due to the operating room environment, for example, the air of the operating theater, or from any surgical materials that were brought into the sterile field during the procedure. Good, so we have seen that these big four are a major threat, right? But there is excellent news, because we know that a lot of them are preventable. And what we see is that from studies is that up to 55%, so more than half of all healthcare associated infections can actually be prevented. So that's very good news. And we see that if we follow evidence-based interventions for the prevention of these infections, that we can obtain reductions up to 66% of cases of ventilator-associated pneumonia, up to 62% of cases of catheter-associated urinary tract infection, and up to 55% of cases of central line-associated bloodstream infection. So this is marvelous. And how can we do that? Well, first of all, let's have a look at our big four again. And what we have seen is that 3 of these big four are associated with the use of those medical invasive devices. And therefore, we also call them device-associated infections, right? Now, there are 3 very, very simple, but even very, very, very important rules that we should apply to any invasive device. And the first one is that we should only insert invasive devices when it is essential, when we can't do but insert them, when we have no non-invasive alternatives. And if we do so, we should do so following sterile aseptic technique. So that's rule number 1. Rule number 2, if you have those invasive devices in place, they should be maintained carefully. And of course, avoiding all unessential manipulations that can cause contamination of the device. And the third one is that all devices should be removed as soon as they are no longer essential. Very simple rules, but very, very important to follow. Now, if we apply these basic rules to the endotracheal tubes, for example, then we see that instead of intubation, of course, if possible, that it is so much better to choose non-invasive ventilation. Ventilator circuits should not be changed routinely, but only if they are visibly soiled or if they are not functioning properly any longer. Also, the materials that we use for respiratory care should be sterilized and disinfected in an appropriate way and following guidelines. There are guidelines that are issued by the Centers for Disease Control and Prevention by the CDC. And daily, we should combine spontaneous breathing and awakening trials in order to get the patient off the tube as soon as possible. Very simple rules. We can also apply them to central lines. So if we insert a central line, we should use aseptic techniques, and very important, use maximal sterile barriers. This is not always the case. It is very important to do so. If we have catheters that have been inserting during emergency situations, they need to be replaced as soon as possible. And if we do need to place a catheter, then we should think about which one is the most appropriate. We should think about the purpose for which the catheter is necessary. We should think about the estimated duration that it will remain in place. And we should restrict the number of ports and lumens only to the number of only to the number of ports and lumens that are strictly necessary. Right. So daily, we should evaluate and manage the insertion sites in an appropriate, sterile, aseptic way. And as soon as the catheter is no longer essential, it should be removed. Okay, urinary tract catheters, same things. Only if there are no non-invasive alternatives, then we can do it. Then we can put an indwelling catheter. We should secure them properly. Both in males and in females, use the smallest bore possible of catheters. Also, that closed drainage system, that is so very important. It should be closed at every moment. It should be maintained closed. Catheters are not to be replaced routinely, neither are bags, only when they are malfunctioning, when there's really a need to. And as soon as catheters are no longer essential, they must be removed immediately. So very simple rules, but there are more rules. There are, of course, also specific evidence-based guidelines for each of the Big Four. Now, in a 30 minutes webinar, there is no time for going into these. So I have listed here the references for these guidelines. The full references are at the slides at the end of this webinar. But what is important is that you should know that you can download them all freely from your home. So they are not access restricted. You can download them from your home. Please be aware that these are very important guidelines. So it would be wonderful if you would take time to read them and to study them too. And then, there are some more things that are essential for successful infection prevention. First of all, we should never forget the standard and the transmission-based precautions that you all know. I'm sure you all know them, and I'm sure you all apply them also today, because they are valid for every patient in every setting, but they still remain the cornerstones of infection prevention. And this is very much valid for hand hygiene. If we have very sophisticated catheters impregnated with, coated with antibiotics, if we have very sophisticated dressings and other technologies, please be aware that you will not avoid infection with these sophisticated devices if you touch them with hands that are not clean. So this is very important that you also apply the standard and transmission-based precautions. And then teamwork, of course, continuous learning, because knowledge is always temporary, patient-centeredness, a good clinical observance, sustained adherence to the guidelines, and absolutely also empowerment. And what do I mean by empowerment? Well, you should be an empowered nurse. If you are there and a device is placed and you see that there are breaches in the aseptic procedure, please tell your colleagues, tell the attending physician that you have noticed them, and tell them to stop the procedure. Tell them to stop the procedure. It is not only your right, but it is your duty to do so as the patient's advocate. So please be an empowered nurse. And if we do all these things, well, I'm sure that we will all manage to prevent infections in the ICU in a successful way. As take-home messages, well, healthcare-associated infections and thereby sepsis are very common adverse events in the ICU, and they are associated with important unfavorable outcomes. The Big Four account for 80% of high, but luckily up to 55% of these infections are preventable. So sustained adherence to those guidelines, to strategies for infection prevention and control is really key to successfully prevent high. I have added all references that I have used, and of course also the references for those guidelines for the prevention of the healthcare-associated infections here. There are quite a lot. Also, if you would like some further reading on the topic. And now I thank you so much for listening to this webinar. I wish you lots of success with the course. I wish you lots of success with your career. And if any questions or comments would come up after viewing this webinar, please feel free to contact me by mail at any time. Bye-bye. Thank you very much.
Sonia, thank you very much for this engaging and very informative presentation. I have one question for you. What do you consider nurses' priorities in preventing healthcare-associated infections in the ICU?
Well, thank you for this question, Nikos. Well, I think that the top priority, and I think that I already mentioned it, I try to stress it also in the presentation, is that hand hygiene still remains the cornerstone of infection prevention. And as I mentioned in the presentation, everything we do to prevent infections is useless if we do it with contaminated, unclean hands. So I think that this is a very, very, very big point of attention for ICU nurses. The more, because we know that adherence to hand hygiene recommendations is very, very restricted in the ICU. It is even more restricted in the ICU than it is in general wards. I have read studies that tell us about an adherence rate of 30% only, compared to 50 to 60% in general wards. And well, as I also mentioned, in the ICU, we have there the most vulnerable patients. So it is a very simple measure. We all know that we have to do it. We all know how to do it. We have all the tools to do it. We have all those solutions. We have sinks to wash our hands. And apparently we still don't manage to do it properly. So I think that it is still a priority to be aware that this is and will always remain the cornerstone of all infection prevention efforts. Not sure if this answers your question.
Of course it does. And just to mention, that goes along not only nurses and allied health professionals, but every healthcare professional in ICU.
Oh, definitely, Nikos, definitely. Nurses, physicians, all healthcare professionals are guilty of low adherence. Absolutely, yes.
Thank you very much again, Sonia. It was great to have you and present this prevention of infections in ICU. Thank you.
Thank you. My pleasure, Nikos. Thank you very much.